In this explainer, we'll be covering the microbiology of acquired immunodeficiency syndrome, or AIDS. We're going to focus on the virology, pathogenesis, clinical progression, and, of course, the laboratory diagnosis of its causative agent.
All right, let's start at the very beginning with the fundamental virology and genetics of the human immunodeficiency virus, or HIV. To really understand the disease, you first have to understand the virus itself. So, as we know, HIV is the etiologic agent of AIDS. It's classified as a lentivirus, which is a subgroup in the Retroviridae family. And that name, retro, is a nod to its really unique ability to reverse transcribe its RNA genome into DNA. There are two main types you need to know: HIV-1, which is the more common and aggressive one found worldwide, and HIV-2.
Now, if you look at the virus particle itself, the virion is spherical and has an envelope, measuring about 90 to 120 nanometers. The core is really what's important here. It holds two identical copies of single-stranded positive sense RNA. And packed right alongside that RNA is the key enzyme that makes it a retrovirus, reverse transcriptase. This is the enzyme that builds a double-stranded DNA copy from the virus's RNA template. That DNA then gets integrated right into the host cell's own genome, and at that point we call it a provirus.
This diagram gives us a great look at those key structural parts. That outer envelope is studded with these glycoprotein spikes. Each spike is made of an outer cap, called GP120, and a transmembrane portion, GP41, that anchors it. Inside the envelope, you have the nucleocapsid, which is made up of the main core antigen, P24. And it's this P24 protein that forms a shell around the viral RNA and the reverse transcriptase.
The viral genome has three major structural genes that are absolutely critical to know. First, the GAG gene, which codes for the core proteins, including that diagnostically vital P24 antigen. Next is the NV gene. It codes for a precursor, GP160, which gets snipped into the envelope glycoproteins GP120 and GP41. These are essential for getting into a host cell. And finally, you have the POL gene, which codes for those crucial viral enzymes, reverse transcriptase, integrase, and protease. All three are major targets for our antiretroviral drugs.
And that brings us to the clinical side of things. Why do we care so much about these proteins? Well, the P24 core antigen is especially important because it's the earliest marker of HIV infection we can detect in the blood. It actually shows up before the body has even started making antibodies, during that period we call seroconversion. So, finding P24 tells us there's active viral replication happening right now.
Now, one of the biggest challenges with HIV is that it changes a lot. This antigenic variation happens because its reverse transcriptase enzyme makes a lot of mistakes. It's very error-prone. This high mutation rate has led to HIV-1 being classified into different groups. Group M, for major, is the one responsible for the pandemic. And within Group M, you have subtypes A through J. For example, subtype C is the most common one in India, whereas subtype B is more common in the Americas and Europe. HIV-2, on the other hand, is less virulent. It's actually genetically a bit closer to the simian immunodeficiency virus, or SIV, and you mainly find it in West Africa.
Okay, now that we have a handle on the virus itself, let's dive into pathogenesis. We'll track the whole process, from the moment the virus gets into a host cell all the way to the eventual collapse of the immune system.
The replication cycle of HIV can be broken down into 5 main stages. It all kicks off with attachment and fusion. That's the virus latching onto and entering a host cell. Then comes reverse transcription, where viral RNA becomes DNA. After that is integration, where that new viral DNA gets inserted into the host's own genome. Then the host cell's machinery is hijacked for transcription and translation of viral proteins. And finally, all the new viral parts assemble and bud off from the cell to form new mature viruses.
This illustration really shows the whole cycle in detail. So it starts when that viral envelope protein, GP120, binds to the CD4 receptor on a target cell, usually a T helper lymphocyte. But that's not enough. It also needs to bind to a co-receptor, which is usually either CCR5 or CXCR4. Once that happens, the GP41 protein goes to work, causing the membranes to fuse and letting the viral core slip into the cytoplasm. Inside, reverse transcriptase does its job, making viral DNA. That DNA travels to the nucleus and is inserted into the host's DNA by the enzyme integrase. Now, this provirus can just sit there, latent, or it can become active, churning out new viral RNA and proteins. These pieces gather at the cell surface and bud off, and then the protease enzyme makes the final cuts to form a mature, infectious virion.
So the absolute central event in HIV pathogenesis is the relentless destruction of CD4 plus T helper cells. Losing these cells is what cripples the entire cell-mediated immune response. A key thing you'll see in the lab is the inversion of the normal T4 to T8 cell ratio. What's also happening is this polyclonal B-cell activation, leading to hypergammaglobulinemia. Basically, the body is making tons of antibodies, but they're often not very specific or effective. And it's not just the T cells. The function of other critical immune players, like natural killer cells and cytotoxic T lymphocytes, gets severely impaired too.
In an untreated person, the clinical course of HIV infection is pretty predictable. About 3 to 6 weeks after they're exposed, they might get an acute flu-like illness. That's the seroconversion phase. After that, they enter a long period of clinical latency, which can last a decade, where they feel fine and are asymptomatic, but the virus is still active. This can then progress to what we call persistent generalized lymphadenopathy, or PGL, and then AIDS-related complex, or ARC, where symptoms like fever, weight loss, and diarrhea start to appear. The final stage is, of course, full-blown AIDS, which we define clinically as a CD4 count below 200 or the appearance of an AIDS-defining illness.
This profound immunodeficiency basically rolls out the welcome mat for a whole host of opportunistic conditions. So in this section, we're going to look at the common infections and malignancies that crop up when the immune system is severely compromised.
And these images show some of the classic things we see. On the left, you've got severe oral candidiasis, or thrush, along with those characteristic purplish skin lesions of Kaposi's sarcoma. On the right, that's a micrograph showing PCO girovagy, a fungus that causes a really severe, often deadly pneumonia in AIDS patients. These are all things that a healthy immune system would handle with no problem.
If we break it down by organ system, the respiratory system gets hit hard by things like Mycobacterium tuberculosis and Pneumocystis jirovecii. The central nervous system is very vulnerable to toxoplasmosis and cryptococcal meningitis. In the GI tract, we often see esophageal candidiasis or severe diarrhea caused by pathogens like Cryptosporidium. And finally, the two big malignancies associated with AIDS are Kaposi's sarcoma and non-Hodgkin's lymphoma.
All right, let's switch gears to how we actually diagnose HIV infection in the lab. We'll go over the different types of tests, antigen, antibody, and nucleic acid detection, and also look at the strategic algorithms that are used to confirm a diagnosis.
This graph is incredibly useful because it shows the timeline for diagnosis. Right after infection, there's a Windows period where antibody tests will come back negative. But during this exact time, viral replication is soaring, and we can detect the P24 antigen. A little later, IgM antibodies start to show up, followed by IgG antibodies which persist. So being able to detect that P24 antigen is what allows us to diagnose an infection before seroconversion even happens.
Lab diagnosis isn't just one test. It's typically a two-step process. We start with screening tests, like an ELISA or a rapid test. These are designed to be extremely sensitive, meaning they're great at picking up any potential positives, but this can lead to some false positives. That's why any reactive screening test must be followed by a confirmatory test, like the Western blot. Confirmatory tests are highly specific. They confirm that there are indeed antibodies against specific viral proteins like P24, GP41, and GP120.
Now, different places have specific protocols. In India, for example, the National AIDS Control Organization, or NACO, lays out testing strategies. Strategy I is all about ensuring the safety of blood products. It uses just one highly sensitive test. If that test is positive, the blood unit is simply thrown away. If it's negative, it's considered safe. The goal here is maximum safety for the blood supply, not individual diagnosis.
Strategy IB is what's used for people who are already showing clinical symptoms of AIDS. This one requires 2 different tests. If they both come back positive, the person is confirmed positive. But if the first test is positive and the second is negative, what we call a discordant result, then a third, different test is brought in to figure out the true status.
And for asymptomatic individuals, let's say someone at a voluntary screening center, the most stringent algorithm is used, Strategy 3. This one requires the sample to be reactive on 3 different tests before a positive diagnosis is ever given. This really minimizes the chance of a false positive result in the general population.
Okay, so once a diagnosis is confirmed, the focus shifts to monitoring the disease and managing the infection. This means tracking key lab markers and getting the patient on antiretroviral therapy.
The single most important marker for checking a patient's immune status is their absolute CD4 plus T cell count.
When that count drops below 500 cells per cubic millimeter, that's a major red flag. It tells us there's significant immune suppression and a much higher risk of disease progression.
But the definitive threshold for a diagnosis of AIDS is a CD4 count below 200 cells per cubic millimeter. At this stage, the immune system is severely compromised. The risk for life-threatening opportunistic infections is sky high, and this is the point where we would typically start prophylaxis for things like pneumocystis pneumonia. The cornerstone of modern treatment is highly active antiretroviral therapy, or HAART. This is a combination of drugs that hit different stages of the viral life cycle, and together they can suppress the viral load to undetectable levels. But, and this is so important, HAART does not cure the infection. Patient adherence to the drug regimen has to be incredibly strict. If not, drug-resistant strains of the virus can emerge very quickly.
Okay, to wrap things up, let's do a quick high-yield review of the absolute must-know concepts and markers, especially the kind of things that show up on exams.
So here are the key takeaways. The cause? HIV, a lentivirus. The key genes? GAG for P24, POL for reverse transcriptase, and N for GP120 and 41. Pathogenesis? It's all about the infection of CD4 plus T cells. The definition of AIDS? A CD4 count below 200 or an AIDS-defining illness. For early diagnosis, you're looking for the P24 antigen. The gold standard for confirmation is the Western blot. For monitoring the disease, you're tracking the CD4 count and viral load. And the standard of care for treatment is HAART. And that concludes our overview of acquired immunodeficiency syndrome.